All right, so I don't think anybody will have difficulty seeing it today. All right, that's good. So what we're going to cover today, we've gone through some parts of cardiac ultrasound. We've looked at the long axis, the subxiphoid view. So today we're going to look at alternate views. There's two alternate views, and those views are the parasternal short axis and the apical view. All right. And then we're going to look at some cardiac pathology. And you guys were here when we videotaped Dr. Biela, and he was our model. We're going to go through a whole little echo just to show you some of the pitfalls and what you can see, what you can't see, and how it can be done on our machine, and that you can actually see the heart quite well. So that's why it's a bit long. We've got a few videos to watch, and then we're just going to concentrate on some pathology after that, right? So this is the first video that we're going to watch. It's the cardiac short axis, and yeah, let's see how it looks on this screen. Well,
and as you recall, when we were obtaining a parasternal long axis, we were pointing transducer marker either to the right shoulder or to the left hip, depending on what convention you were using. So in the case where you're operating under the cardiology convention, you would have the transducer marker pointing towards the patient's right shoulder. And then to get a short axis from that, all you have to do is to rotate the transducer 90 degrees clockwise and point it towards the left shoulder. Alternatively, if you had the transducer pointing towards the left hip, operating under the emergency or abdominal setting, then what you're going to do to get the short axis from the long axis, or your home base view, would be to, again, rotate it 90 degrees and point it towards the patient's right hip instead. And that's what this would look like, kind of rotating it clockwise. Okay, and because you had it centered around the mitral valve, that would generally be the level that you expect to see. So here we have the heart again, and what we're going to do is to do a cross section like so, and we're going to rotate that, and this is the view that we're expecting to see. So as you can see, if you had it centered around the mitral valve, what you're going to want to do is to actually scan it a little bit lower to try to catch the papillary muscles. I didn't really catch the second one here, but you kind of get the idea. So that's the image that we are going to obtain on ultrasound. And here you can see that we went from parasternal long axis to parasternal short, where you can, right there, and then rotating, and then you get the mitral valve in view right there. Okay, so the papillary muscle should show up, and this is really the view that we're trying to obtain in the parasternal short axis. And the anatomy will go over as such. So what you have is the left ventricle on the right-hand side of the screen, and the right ventricle on the left-hand side, the septum being right here. Ideally, the ventricle, in the absence of pathology, should look fairly round and concentric. And then you have your anterolateral papillary muscle over here, and your postural medial papillary muscle over there. You don't need to, but if you're for more advanced users, you may want to actually scroll through the heart to look at different aspects of the heart. So you can kind of tilt or angle a little bit towards the apex. Kind of to look down towards the apical region. Or alternatively, you can also sweep up or tilt your transducer to have a look at the aortic valve. Okay, so that's what that movement would look like. Here we have kind of tilting towards the apex, which is located over here, and then tilting up to look at the aortic valve. So anatomically, these are some of the structures that you're going to see. You have your mitral valve, and then you see the papillary muscle. As you look towards the apex, the ventricle should get smaller. As you tilt back up, the first valve you should hit is the mitral valve, which is a bivalve. We call that the fish mouth view. And then as you tilt up even further, you should start seeing the aortic valve, which is a tri-leaflet, unless you have bicuspid aortic valve. Again, your right side of the heart's over here, and the left side of the heart's over there.
Okay, so that was just,
Okay, so here we have the bileaflet mitral valve over here. And then as you start to scroll back up, you're going to start seeing what we call the Mercedes signs, or the tri-leaflet aortic valve. So let's go through some of the structures a little bit more closely. So this is, again, the bileaflet fish mouth view of the mitral valve. And anatomically, you're looking at the septum here, right ventricle here, anterior mitral valve over here, and then posterior mitral valve on the bottom. And then as you scroll up to look at the tri-leaflet aortic valve, this is the Mercedes-Benz line. You have your right atrium here, tricuspid valve here, right ventricle going through. You can see a hint of the pulmonic valve as well. So anatomically, you're looking at the 3 leaflets of the aortic valve, and then these are the other structures that may be important for some of the other pathologies that you might look for, such as an embolus, etc. So the take-home points.
I should just get it. It's quite boring, but you can't beat the animation that they've got on these, so that's why I chose it, right? So we're going to watch one more of us, unfortunately, all right? And this is now to show us the apical views, all right? So, and then after that, you'll watch the one that we did, and then we're going to go through some pathology. So don't worry, it does get better.
This is where the apical 4-chamber view cuts through the heart.
Sorry. Yeah, I remember I changed.
The probe is now down here, scanning from the apex. The first structure it's going to encounter will be the apex of the heart. As its name describes, in this view, the imaging sector passes through all 4 cardiac chambers, with the atria furthest away from the probe. So now we're going to move on to a completely different echo window. We're going to the apical window to get a series of apical views. So this means putting the probe on the apex beat with the notch angled towards the left shoulder. And the trick is to get the view as well as you can, as far down the chest as possible, so you're not foreshortening. Just to move a tiny bit towards me, that's it. If you've got a cutout on your bed, it's really useful to get the angle of the probe here against the chest, so you can get a apical 4-chamber view like this. And this is a diagram of the apical 4-chamber view. As ever, our probe is positioned at the top of the screen. The first structure we're going to image is the LV apex, and then the cavity of the left ventricle. We have the right ventricle here, the right atrium, and the left atrium. This is the mitral valve. This is the tricuspid valve. In a normal heart, the left ventricular apex forms the apex of the heart. If the right ventricle becomes dilated, it can push it over. But this is a normal situation we're looking at here. We've got 3 of the 4 pulmonary veins coming into the left atrium, and then this circular structure outside of the heart, so it's outside of the pericardium, is the descending aorta. So this is my apical 4-chamber view. It's a really nice view of seeing all the chambers laid out side by side, so you can see their relative sizes. So we can see that the right ventricle is about 2/3 of the size of the left ventricle. We can see that the atria are very similar sizes, and they're considerably smaller than the 2 ventricles. So if we move slightly to focus on the right ventricle, so I've just moved my probe very slightly inwards, really, towards the spine. You can see how trabeculated, so all these ins and outs of the right ventricular free wall, and we can see there are sort of cords going across the cavity of the ventricle. One of these is probably the moderator band. So this is what a normal right ventricle looks like. Another thing I'll be checking whilst I'm on the right side is the relative positions of the 2 valves, so the tricuspid, which is here, and the mitral valve. And we expect the tricuspid to be nearer the apex, near the heart's apex, than the mitral, which you can see here. It's only a small offset, and that's fine. It's usually sort of around 5 millimetres. If there's no offset and the valves look like they're in a line together, that would make you start wondering whether there was congenital heart disease. So having looked at the right ventricle, I'll slightly move my probe to bring the left into view. So it's a nice view to look at the function of the ventricle, so how the walls are all moving in and whether they're moving in similarly. I can assess the valves really well here, so the tricuspid and the mitral valves, so I'll be putting some colour on like this. So this is the red is forward flow through the tricuspid valve. I can't see any tricuspid regurgitation, and then I'll do exactly the same thing over on the mitral valve. I can see the interatrial septum quite well, which is here, but I'm not very well lined up for flow across it. So whilst I could put colour across, I'll probably want to look in a subcostal view to check if there's any ASD or PFO flow. So we can measure cavity sizes, we can measure diameters, we can do areas or volumes of the atria in this view. It's also nice for looking for pericardial effusion, and again I would be moving my view around a bit. If I wanted to see if there was any fluid around the heart, I could pull the LV over like that, and then I can pull the RV over like that. I'm just checking whether there's any fluid all around the heart. But there isn't. This is a nice normal echo.
Okay. But there's one little caveat to this whole thing. Notice what she's using, all right? That's a cardiac probe. It's basically the same as our probe, but it has a very small footprint, all right? So it can get in between the ribs. So that's why they're getting such beautiful views. Now in our case, we don't have that luxury. So that was the reason last week we brought our student, Biela Malusi, put him on the bed here, and then we actually did a full echo for him, all right? Based on what we have available to us, just so that we could see what it looks like. So unfortunately, the next video is a bit boring, but it's to show you what full echo should look like using our machine, and basically the type of machine that you would use in most South African public hospitals. Because you don't have many echo technicians, those echo technicians will use the cardiac probes. Each probe is 140,000 rand. So if you're lucky enough to work in an emergency department that has an ultrasound machine like us, the best you can hope for is the curvilinear probe that we have, right? Those straight probes, those only radiology, because that's another 200 somewhat thousand. So you don't expect those, all right? So let's just get past that. All right, so here's a bedside echo in our emergency department with our equipment, all right? So let's watch that. It's a bit long, but I hope you will enjoy it.
So today what we're going to practice is a full echo, all right? A bedside echo.
The first, why did nobody tell me I sound like this? It sounds like I have a hamster stuck up my nose. So all this time I thought you were laughing with me. Now I know you're laughing at me. All right. Okay, let's get back. Sorry.
For a patient. So let's pretend that our young Dr. Biela here came to us with chest pain, and that we need to have a look at what's going on. We've done our ECGs, we suspect something's going on, but we're not 100% sure what could be going on. So that's when our echo comes into it, all right? Now, we are not echo technicians. That takes months of training, actually. It's about actually 2 years of training, sorry. So what we're trying to do is just see if we are in an emergency department setting, what are we going to look at? So this is just a revision and to introduce you guys to the two other views that we use, all right? So thanks, Malusi, for volunteering. You will live on forever. Our grandchildren shall speak of your sacrifice. No, I'm just kidding. All right, so the first thing we're going to do is a subxiphoid view, all right? So the subxiphoid view, what we do, we place our probe just below the xiphisternum, all right? And then we apply a bit of pressure. So if your patient is peritonitic or having abdominal discomfort, this can be quite painful for them. So you've got to take that into account. Now, if you look at the screen, we start getting an idea of what Malusi's heart looks like, all right? So the most important thing also when you're doing ultrasound is just to make sure you can see whatever you want as a complete picture. So if you want to, you can just have a look at the probe here. So you can see what I'm doing is I'm moving it up and down, I'm moving it side to side, I'm rocking it back and forth, trying not to cause too much of discomfort until a point where I can actually get the picture that I'm looking for, all right? Now, what we can is because he's got lovely big abdominal muscles, all right? So you can see I've been doing a lot of ab workouts and things like that. It means that the heart is sitting at about 12 centimeters down. All right. It also tells us that we are going to have to move around a little bit in order to see everything. So sometimes if you are lucky, you can see everything in one go, and sometimes you'll see it in little bits. So let's start with what we can see. So the first thing that we see is the right ventricle. So that's just a bit of gas from his tummy, and that it will eventually go. All right. So here we can see the right ventricle, and we can see the right atrium. All right. And there we can see the tricuspid valve that's actually pumping away over there. If we want to see the left ventricle, we have to try and look a bit more posteriorly, and there we see his left ventricle. Now there is a bit of bowel gas, which is fine. It's early in the morning. He hasn't been to the bathroom yet. We understand. Don't stress, you know. So, but these are the pitfalls that you face. So we can see we've got a nice right ventricle, we've got a nice left ventricle, but we can't see our left ventricle 100% over there. So that means we've got to try an alternate view. So the first alternate view that we use is the long axis, which we've already had a look at before. So we try and get in between the ribs, okay, with our indicator pointing towards the left shoulder. So I just want to show you guys. So I'm touching the side of the indicator, right? That what you see over there, that movement. So what it means is that we're actually seeing a mirror image of the heart. The apex is not at the top left-hand side. So in other words, the apex is not here. The apex is more towards the nipple side, right? But we do this just to make it a bit easier for us to envision what's going on, right? But now can you see the difference? We can see a right ventricle. We can see a beautiful left ventricle over here. We can see a left atrium. We can see a mitral valve. We can see a bit of the aortic valve. We're going to try and find the descending aorta. Let's just get it there. There we go. That's a bit of the descending aorta over there. And we can see the pericardium as well. Right? So this is actually the best view in which to get your ejection fraction. And ejection fraction is actually quite easy. So the first thing that we're going to do, let's just freeze this. All right. Now, you can focus on this. Let me show you what we're doing. So this machine, most machines have this little rewind function and forward function. So can you see what's happening there as I'm moving? I can actually move back and forward a few frames. All right. So what we're going to do is we're going to see this heart in diastole. All right. So in diastole, in other words, at its maximum diameter. All right. And we're going to measure that. So let's put measure. All right. And we're going to measure the width. All right. Let's set there. And we come across and we set there. So we've got 3.5 centimeters. Okay, so in other words, that's our maximum diameter. All right. And then what we're going to do is that let's take it out from there. Sorry, I just need to exit from that. Where's the back now? It's somewhere here. Let's take it out from there. Okay, let's measure. Oh, it's just not moving forward. All right, let me unfreeze it. We'll just get this again. Sorry. So we know our maximum is 3.5. All right. So now we're going to come to our minimum. All right. So we're going to look at how small the thing gets as well. So let's try and catch it there. So we try and find it at its smallest diameter, which is more or less there. And let's just measure it again. All right. So we had 3.54. Has somebody got a calculator out? On your phone? Yeah. Right. So the widest that it gets is 3.54, or let's just say 3.5, all right, just for simplicity's sake. So his widest diameter is 3.5 centimeters, and his smallest diameter is, let's say, 2 centimeters, all right. So for simplicity's sake, the difference is the diameter, maximum diameter, minus the minimum diameter, which comes to 1.5 centimeters, all right. And then you take that, 1.5, divided by the maximum, which is 3.5. So what's 1.5 divided by 3.5? Sorry, 0.42. Multiply that by 100. 42. So 42% is his ejection fraction. And that's how you work out ejection fraction. Simple. Okay. There's another way that we can work it out, and I'll show you guys now. So we're going to concentrate again on, let's just have a look at the buttons here, all right? Yeah, sorry.
Which is the ideal ejection fraction?
Anything above 30% to 80. Not to 80, sorry. Let's say from 30 to 70 is ideal, all right? But you've actually got a very healthy heart because of your running and things like that. So the other way that we can use is that we can use something called motion mode, all right? So I want you to see what happens when I press that. Okay, and we place the cursor in the middle. Okay, so can you see the pattern that forms over there? All right, so this pattern that forms in motion mode is actually showing us basically the maximum and minimum diameter as well. Now they're all together. So let's try and measure again. So we're going to go from here, set, let's go to there, 6.8, all right, because it's measuring the entire ventricle, all right. So that gives us 6.8. Let's just set it there. And then let's take the minimum. Oh, sorry, that's the minimum, sorry. So this is where the walls are closest together. In fact, sorry, let me do another one. Let's start with the maximum, sorry. So we start from there, 6.8. So that's about, let's say 8 centimeters, all right. And then the minimum is going to be from there till about there. So it's about, let's say 4 or so, all right. So it's working out to about 8.2 minus 4.4. So it's just less than 50%. So if we had to work it out using the same formula, so you take 8.2 centimeters minus 4.38 centimeters, the difference divided by 8.2. So it'll come out to also approximately there, all right. Now the only way to work it out 100% for sure is to measure a few of these over time. But it can give you a basic ejection fraction, right? So all those fancy ejection fractions that you see, that's basically what they do. All right, nothing else. And you can see ours also gives us an opportunity to work it out, but that's a bit complex. We don't want to get into so much of detail, right? So let's come out of motion mode. So we've had a look at his heart in 2 planes. Now, let's say we couldn't see the ventricles properly for whatever reason. Let's say there were rib shadows or something like that. They were passing across like this. Let's say somebody's got very close ribs or something. Then what we can do is we can do something called the short axis. Now, when we're doing the presentation, you guys would have already seen this and the explanation of how the short axis works. But basically what we're doing is that we're looking at the heart in cross section. So we're starting at the apex. So that's the apex of the heart, all right? And then we're slowly but surely coming up, looking at the right ventricle and the left ventricle, all right? And do you see this fish mouth that's happening over there? That's our mitral valve, right? So it gives us a good view of our mitral valve. Then we can move a little bit more. Now his ribs are coming a bit in the way as well, but we can also see the aortic valve at times. So that's more of the mitral valve there, and that's the aortic valve over there, right? And sometimes you can see the tricuspid, but not on him, unfortunately, in the meantime, right? So there we've got mitral valve pumping away over there, right? You can see like a fish mouth opening and closing, and you can see the aortic valve just hiding behind that rib. So it's a little bit difficult to see. So the short axis is very good to tell you the ratio of your right to left ventricle. In his case, you can see we've got a nice D-shaped right ventricle and a nice thick left ventricle over there. That's kind of giving us a good view. There we can see it a little bit better, all right? We can see our septum, we can see everything. So we start to get a more clearer picture of the heart. As you come closer to the sternum though, you lose it a little bit, all right? So this is normally where you'll see the best picture, all right? So we see right ventricle and we see left ventricle. So that's where the short axis is of great value, all right? Now let's say if we want to see the whole heart, the last thing we're going to look at is the apical view. So the apical view, what we do in that case is that we ask our patient to turn onto the left-hand side. So Melissa, if you can turn onto your left side for me, all right? What this does is this moves the heart anteriorly, just a little bit more. So you're going to basically lie on your left side and come a bit more towards this side. Yeah, sorry, I won't let you fall, don't worry. Okay, now you're going to just come here, just lean a little bit just so that they can see what I'm doing. So what I'm doing now is that I'm basically getting to the apex of the heart and pointing directly through. Right, so I'm going to try and find the apex as well as I can. There we go. All right. So what I'm doing is now shooting through from the apex through to the back of the heart. So what this does, it allows me to see the entire heart in one fell swoop. All right. So what we see, oh, sorry, I put it the wrong way around. That's why it looks so funny. The indicator was the wrong way. All right. So what we see is that we see the right ventricle, left atrium, right atrium, tricuspid valve, mitral valve. And if we move around a little bit, we might even be able to see the aortic valve. Can you see it there? This little thing that's pumping away over there, all right? Okay, can you see it over there? So this is also called the 5-chamber view sometimes because you can see all of the heart at the same time. So this is just to give you an idea, and you can see what a good view it is, all right? Because compared to all of the other views that we had, we've actually got the best view of the heart from the apical view. Now there are some caveats to that. The patient needs to be relatively fit and in good shape like what Malusi is. You can't have somebody with large amounts of breast tissue, adipose tissue. It can become a bit difficult. And sometimes rotation of the heart can make it a bit difficult as well. Ideally, what you want is you want the septum to be absolutely perpendicular so that you get absolutely correct measurements, but it's not always possible in a real setting, all right? So basically what we have now is we've learned 4 different views of the heart, okay? And those 4 different views of the heart allow you to look at a whole lot of different things. So during this presentation, we're also going to look at stenosis, regurgitation, and things like that. But for right now, this was just to show you a echo on an actual patient, all right? So Malusi, thanks a lot. We really appreciate it. All right, and you've got a very healthy heart. Don't worry. Okay.
So there's 2 very important things that we learn from that. The first and most important thing is that even with the limited equipment, if you can put it that way, that we have, you can still get a relatively good picture of the heart. You can still get a relatively good view of the heart, depending on which side you choose to view it from, right? So as we could see there, eventually with the apical view, we could see his heart absolutely perfect, even though he had bowel gas, his right ventricle was covered by the sternum and things like that. And the second thing that we learned from this video is that somebody in this department has to take charge of telling me when it's time to shave. All right. So either send me an SMS, a threatening email, a picture of a werewolf, because that was horrible. I didn't realize it until I actually But it just shows you it is possible. Even with a larger footprint, you can see everything. All right. So what we're going to, sorry, let's just go back one. So what you're going to do now is we're going to look at some pathology. All right. So this is so that you guys get an idea of what these things look like. Now, it may not always be possible. You must remember, these are all teaching pictures and things like that. So it often looks very nice here, but it doesn't mean that it will look like that. Let me just get the point out. So the first thing we're going to look at is mitral stenosis. All right. So what does mitral stenosis mean? A mitral valve that is unable to move or to open up properly, which we can actually see over here. You can see there's hardly any well, I mean, there is movement and there's actually bowing of the mitral leaflet and things like that, but this is the stenosis side. It's not really moving, all right? So you've got 2 rooms, if I can put it that way. You've got an atrium and you've got a ventricle and you've got a door in between. And you've got a door that's not opening properly. So blood is supposed to go from here to here through a door that's not opening properly. What do you expect to happen to this room? Get bigger or smaller? Bigger, which is what we actually see over here. The atrium is almost the size of the ventricle. And conversely, you expect to see the ventricle getting smaller as well, okay, because it's not receiving enough blood. And then what do you get in terms of murmurs and things like that? You get a diastolic murmur, you may get clicks, a loud E2, I think if I'm remembering it correctly, long time since I've covered all that cardiology. But and then your physical symptoms, clinical symptoms will be tachycardia to try and compensate. You will get low BPs, things like that, all right? And then you've got mitral regurgitation, all right? So here we see the mitral valve in the apical view, all right? So mitral regurgitation basically means now the valve is not working properly. It's just swinging in both directions, all right? So what you're going to get is you're going to get a heart that's basically pumping back into the left atrium. All right, so you'd expect the left atrium to get bigger, all right? And then it conversely also pumps more the next time. So you start getting dilation of the left ventricle as well. You start seeing effects on your blood pressure and things like that. I mean, this is not a tutorial on all of the valve disease. I'm just trying to give you a basic example of what you'll see. But here you can see the regurg, all right? Sorry, let's get it up there nicely. So you can see it just opening up and you see flow going both ways. Okay, so something interesting to see. Let's go to another one. Aortic stenosis. So here we're seeing the aortic valve, right? Now this is in the parasternal long axis view. So now we've got a ventricle that's enlarged because it's trying to push through a door. So it becomes hypertrophied. But the main thing is aortic stenosis has a lot of clinical signs that you need to look out for, right? So it's known as SAD, all right? Any idea what it stands for? Syncope, angina, and I'm going to go and learn it, all right? But basically, you're not receiving enough blood into your aorta, all right? So what happens is your patient has syncope because they're quite honestly, they're not receiving enough blood. You'll figure out the other 2 and you'll let us know, okay? Can't give you everything. It's not a spoon feeding session, okay? And then you have aortic regurgitation, all right? So what happens in aortic regurg? Why did we put mitral regurg again over there? All right, but anyway, it's a similar picture. So what happens is that your aortic valve starts regurging, all right? So everything gets pushed up into the aorta and then falls back down. And the biggest sign of that is wide pulse pressure, all right? So what does a wide pulse pressure mean? It means you have a massive systolic and a very low diastolic, all right? Because in order to overcome the regurg, your ventricle has to push extremely hard. So all the blood goes into a tube. And then from that tube, everything falls back inside. So your blood pulse pressure is extremely wide. Okay. So these are all interesting things. And hopefully when we do valvular diseases later on, we'll discuss it in more detail. But I can see everybody's coffee hasn't kicked in yet, so we're not going to go into it in too much detail. Then you have tricuspid stenosis. All right. So here's our tricuspid valve over here. And we can see it's not really moving too well. So we expect right atrial enlargement, right ventricular constriction, things like that. All right. So that's what it looks like. And then tricuspid regurg, which is basically similar to mitral regurg, just that it's affecting the right side of the heart. Okay. So the interesting thing with this, the worse it gets, the more it mimics abdominal aortic aneurysm, because eventually all the blood starts getting pumped into the IVC. So we've had a few patients when you touch the abdomen, it's actually bouncing up and down, and you think it's a AAA, but when you go there, it's actually mitral regurg. So just an interesting thing to look out for, right? But that's basically what it looks like in ultrasound. Will you be able to pick it up all the time? Not necessarily, but if you do see it, you know, or if you do suspect it clinically, at least you know what to look for. We're not going to go through the pulmonary valves because in all honesty, those are normally congenital. We don't normally get the kids. We don't normally see it, but it's interesting if you want to see it. And it needs a more specialized view to actually be able to decide, is this really or not, right? So I'm not covering it here. So this is something else that we normally see, papillary rupture. Okay, so what are we looking at here? Any idea? It's a papillary muscle that's basically torn away from the rest of the structure. So it could more commonly tears away from the leaflet, or it can tear away from the mural surface as well. And the most common reason for that is ischemia. Are these patients sick? These patients are extremely sick. These patients need cardiothoracic urgently. These patients, essentially the ventricle is almost non-functional, you know, once it happens. Blood's just flowing all over the place, you know. So they can't keep their BPs up. They really start to crash quite quickly. And that's a whole lecture on its own. So I'm not going to get into too much detail. But just so that you know, that's what papillary rupture looks like. So if a patient is not doing well and you put an echo on and you see, you know, this muscle is just doing its own thing, just be careful. Okay? Something's gone really wrong over there. Okay. And this is something else that we need to see. Endocardial thrombi. Okay, which can be infective in nature. They can be, related to blood clots, things like that. But that's basically what it looks like. All right. So if you see that, you need to get worried as well, because they can throw off clots from here. They can throw off vegetation. So it's quite a bit to see. So that's just a bit of pathology, just for you guys to know. I don't expect you guys to be echo technicians, but at least be able to pick up when something is wrong. And the only way you'll pick up something is wrong if you know what's normal. It's like knowing what a normal chest X-ray looks like. Even if you don't know all the diagnosis of an abnormal chest X-ray, at least you know some things are normal. You can ask and say, okay, this is not looking too good. I have no idea if I have another slide. I do. So this is another interesting one for us to look at. It's hypertrophic cardiomyopathy, right? Which is quite something we see quite often, all right? Surprisingly, but we don't pick it up. So if you look at the left ventricle and you just look at how big it's become, it's a bit of a concern. And the question is, why does it become a concern? Because as it becomes larger, it starts blocking the outflow tract. All right. So if you watch this GIF, it basically shows you what happens. All right. So that's normal outflow tract. And then as you get hypertrophy, it actually starts narrowing. All right. So these patients eventually have problems with outflow, and the hypertrophy gets worse and worse and worse. Any idea of the treatment of this? It's a lovely thing. If you have a chance, go and check it out. It's called a myomectomy. All right, myomectomy, removal of the end of the myocardium. All right, basically to physically remove the myocardial structures. And there's some lovely things. You have a look at this heart on the inside and how they can change it. You want to become a cardiothoracic surgeon, I'm telling you, because it's so amazing to watch. The most amazing thing when I saw this procedure the first time was the sterility of the heart. You know, we really don't realize how sterile the inside of our bodies are. So if you have a chance, please go and have a look at it. So that's the end of the presentation for now. That's just a little joke to finish off, all right? But The most important thing is not to worry about pathology initially. When you're starting to do echoes, is just to get the hang of what's normal. And the only way you can get the hang of what's normal is to examine patients who you do not suspect pathology. So you've got to lie to your patients, unfortunately. So Maya's come in with a left elbow problem. You know it's a left elbow problem, but you tell them, because it's going down the left side, I need to check your heart just to make sure. And spend 10 or 15 minutes just looking around. She'll look worried as well. And when she tells, no, everything's okay. You know what I mean? Nkulu comes in, he's coughing a little bit, he's been smoking for the last 50 years. No stress, put an ultrasound on and you compare the two, and you'll see, this guy has got signs of COPD, pulmonary arterial hypertension. Then you go to a 20-year-old runner who's come with appendicitis and go and put it on and say, we make sure it hasn't gone to your heart and just check it out. There's no problem. Patients won't tell you no. All right. The only time they'll get a bit worried is you're sweating and squinting and looking at the screen like, what the hell is going on here? So just do it. Do it confidently. Even if you're not sure what's going on, they don't need to know that. You're just practicing. All right. You don't suspect cardiac pathology. Okay. But remember, an echo is an adjunct. It's not your primary mode. It's not your primary mode of investigation. So you first investigated this patient through history, physical examination, ECG, bloods, and then your echo comes after that. Your echo is to try and confirm what you've seen before, or to tell you in what direction you should go if it's a bit ambiguous. We had that atrial fib patient the other day, and it was such a lovely thing. You could actually see the fibrillations, you could see the thrombi. You guys were there, you saw it. So it was a nice thing. It kind of confirmed to us what we were seeing. All right, and it confirmed this is really what we found on this patient. So, that's the way that you got to look at it first. Don't go and rush to put an echo on. First do everything else, and then come back to do it. Okay. I hope you guys enjoyed that. I know it was a lot of videos. I also fell asleep halfway through. So you can always go back and watch them at some point because it's impossible to retain all of this, right? Like for me, listen, I've been doing this for years. So I look at them because I know what to do, all right? But you guys have to go back, watch it again, and eventually it becomes like second nature, all right? So don't worry. But any questions, anything that seems a bit worrying, anything that seems a bit strange, now you know it is possible with our mission. That's the important thing, okay? And more or less what to look out for. Okay, not sure if there's any questions from the Zoom crowd or if everybody's happy. Okay, if everybody's okay with it, then we'll end it there. And this Friday, there's no meeting. All right, we'll start again next week with other commitments, interviews, things like that. But we'll do it again next week. All right, just want to thank everybody on Zoom. Bye. All right, guys. So